taken out of the body by the lymphatics or the reticular endothelial system, and some of them have actually caused issues like skin itching and scratching, and skin and to be withdrawn, because they actually just get deposited in the patient's skin, because that's the only way the body could get rid of them. So they're a bit funny. There are some cases for use of albumin, and it has been proven to be useful in certain conditions, but it's quite expensive, and I would generally use that with senior advice. Use it in intensive care to avoid, if you want to give sodium to someone without loads of chloride attached, or if you generally want to plasma expand someone who's sort of like proteinemic or with low albumin, can be useful there. But as a F1, F2, I wouldn't really be prescribing that without being asked to. So I wouldn't worry too much about colloids. But if you're in a TIS and you've got a patient who you're trying to resuscitate and you really want to give something to maintain plasma volume, you can get a bag of gelafusing, but in general they probably wouldn't even know where they're kept on the wards. So I generally avoid them. Here's a picture from Somerset when we could go to other places in the country. That was very nice. Hopefully soon we're back to doing that. I'm going to go talk about fluid balance assessments now. It's a bit hard to get this over sort of like a Zoom format. It doesn't really lend itself well, but we'll go through the basics of the exam and what we're going to pick up. Airway and breathing issues. Obviously, if someone's fluid overload, they're going to get pulmonary edema, increased CREPs and increased respiratory rates. Respiratory rates also quite a sensitive marker of hypovolemia, more so than heart rate and low blood pressure. Those are going to be sort of like slightly later signs. I'll do a cap refill centrally and peripherally just to make sure they're not full. They're going to feel cold if they're shut down. Passive leg raises we'll go into as well. They're kind of useful. They're quite tricky to do in a ward situation, but I'll go through basically how to do one and what you're looking out for. I've highlighted feeling thirsty on the D part of your assessment. We don't often ask when we're assessing someone, and actually if someone's hypovolemic, it's a really, really sensitive marker for someone being intravascularly dry. The body's quite sensitive at picking up low volume states, and part of their the action of vasopressin release or antidiuretic hormone is to stimulate a feeling of thirst, and it's a really, really sensitive marker. So do ask your patients if they're feeling thirsty. It generally correlates well with them being a bit dry. Fluid balance is again a contentious issue in ward-based medicine. Some wards will be really, really good at keeping your fluid balance charts and that sort of thing. Sometimes it's an absolute nightmare trying to get good records. You have urine outputs just done like once every 20 hours or something, and you've got to try and like work out when did they pee, are they not peeing enough. You got to have the magic number in your head as to how much urine you're expecting someone to be producing, which is 0.5 mils per kilo. So look at your sort of your patient's weight and just half it, and that should be your mils per hour you're trying to go for. If you've got someone you're actually having to resuscitate them, try and get them catheterized on your urometer if they're willing to go for it. Because if they're that sick, it's probably worth keeping that close an eye on the urine output. Electrolytes as well. How often you check your electrolytes is going to depend on how sick your patient is and what you're giving them. So passive leg raise. So the idea is you're going to see if you have an improvement in the observations when you do that. You're going to have about 250 to 500 ml blood kept in the veins in the legs. So you can simulate a fluid bolus literally just by tilting your patient's bed back. You need a bed that's going to be able to tilt back relatively quickly. I mean, in A&E and Resus, you've got those trolleys with a handle that you can just tilt down, but doing it on a hospital ward plugged in bed can be a little bit tricky. Things that are going to mess up your readings are like, if you're touching the patient and they're getting stressed, they're going to get like a tachycardia, hypertension, white coat sort of thing. So you might mess with the numbers if you get two hands on. So that's why you want to try and do it with like a bed or a trolley that you can just tilt nice and easily. And it's ideally you're doing this on a patient who you're continuously monitoring. Then that's easier said than done. You're going to be on a ward most of the time. You're going to have a blood pressure cuff that you're going to need to press a button to inflate, and you're going to need to be keeping an eye on the heart rate. So that might be either manual, or it's not ideal, but you get a reading off a SATS probe. But you've got to have some way of getting a before and after reading. So take a blood pressure, get an idea of their pulse. A SATS probe might give you a pulse reading if they're shut down, and might not. Try and tilt the bed and then read it afterwards. And if you're looking for a reduction in heart rate or an increase in blood pressure, and that's going to predict whether someone's going to be fluid responsive or not, fairly well. But it's quite tricky to do in practice. So here's my breakdown of methods of giving fluids. So maintenance fluids is going to be your box standard. Not too fast. You're going to be doing it through a little IV pump, which you can program. Replacing losses. This is going to be the main thing you're doing when you're on take, seeing your acute surgical and medical admissions. And that's when you're going to see, your bags over several hours, whatever. And that's where it gets a bit, sort of personal preference and based on the history, but we'll talk about that in a second. Replacing electrolytes. So sometimes you're going to be needing to IV someone to get their potassium or sodium or whatever sorted out. And the number 4 is your resuscitation fluids. So if you just think about when you're giving fluids, am I trying to just give them the daily requirements? Have they lost volume or solute or something that I'm trying to replace? Or am I actually trying to, IV, potassium or sodium or whatever carefully? Or am I just trying to get volume in to get the heart rate down and get the blood pressure up and perfuse their peripheral tissues? Just think about those 4 different things when you're giving fluids, rather than just going like 8-hour bags and just forgetting about it. So maintenance requirements. This is how much you need of water a day. So about 30 mils per kilo. 70 kilo person, that's about 2 litres. Sodium, potassium, nice and easy to remember, about 1 millimole per kilo per day. So interestingly enough, I was talking about salt content earlier. So 500 mils of 0.9% saline will give you your daily salt or sodium requirements, versus 2.5 litres of 0.18. So that's why we often use the sort of like 5% or 5th normal saline with dextrose on the ward normally as your basic background fluid. Potassium as well, so 60 to 80 millimoles per day. In general, you're going to be putting potassium 22 or 40 in those litre bags if you're given those sort of like 3 litres a day. You would avoid giving potassium when someone's hyperkalemic. If it's over 5, but if it's anything below 5 on your regular user needs, you generally want to be replacing potassium because you don't want them getting low. Calcium, magnesium, and phosphate. There is a daily requirement. You're not really going to be measuring these routinely, but it's something to bear in mind if someone's been malnourished, not eating for a while, or if they've got some sort of chronic disease state, that you might consider measuring it. And obviously as part of your confusion, screen bloods and that sort of thing, that's when you'll be checking those other electrolytes. Interesting to think about the energy requirements of the fluid you're given as well. I've just done a little calculation here to show you how much energy you're actually giving if you give 4% dextrose over 3 litres. And they're getting about 400 calories from that. So not enough to give you total daily allowance, but it's a little bit of help there. And macronutrients as well may not be helpful. I mean, we're not going to be IVing protein or whatever. But I just thought that'd be interesting to know about the calories that we're given with dextrose saline. So the summary of maintenance fluids, we mentioned sodium chloride not being that useful due to the chloride loads. You won't be struck off if you're giving someone sodium chloride as a maintenance fluid. But in general, there are better things, giving match solutions or your dextrose saline. Most of your trusts will have some sort of fluid chart which basically does all the work for you. You work out your patient's weight and it works out the mils per kilo. It's normally about 1 mil per kilo per day or per hour, sorry. So you'll be given, you know, slow rates of fluid, like 50 to sort of 80 mils per hour on your prescription, normally given it with potassium. And you're given a little bit of energy, but not enough to keep them going, especially if they're sick. And in general, your glucose is going to be metabolized to water, so that's important to remember, that that's going to redistribute about amongst all your body compartments. If you're given 4% or 5% glucose solutions to try and resuscitate someone, it's going to be pretty useless, because you're only going to keep, like, you know, 5% of that in your plasma, and the rest of it's going to go to your intracellular and extracellular fluids. So decent for maintenance, but you know, not useful if you're going to try and resuscitate someone. This, I believe, is a picture of actual COVID under a microscope, which is quite interesting. Losses. This is a difficult one to lecture about, because you're going to be trying to match that to what your patients actually lost, and this is going to be history based, or if they've been in the hospital, you know, on your ward for a long time, you're going to be looking at charts and whether they're actually vomiting or have diarrhea losses. Your colorectal wards in particular, there's, you know, stoma charts and fluid output charts is really, really important on these patients. And you often sort of doing these calculations, you get your list of drug charts or your fluid output charts, and you're trying to work out how much is lost over the day, and you prescribe the fluid to replace that. So it's a bit of work and a bit of a faff sitting there calculating it and working it all out. But you know, you're just trying to give them back what they've lost. Your surgical patients being admitted, generally vomiting or generally having diarrhea, or for medical reasons, or the medical take as well. You can get an idea from chatting to the patient how much they've been vomiting or losing from the bowels. The pattern you see on the blood gas is this, from vomiting in particular, is hypokalemic, hypokalemic, and hyponatremic, and low hydrogen, so alkalosis as well. So if you see that on the gas, you've got to think vomiting. Other things that could cause similar patterns are things like, you know, diarrheal loss, or you know, laxative abuse, that sort of thing. That's a bit rarer. Losses from diarrhea and stoma, high output stomas, can vary. So you're normally just guided by your electrolytes, either daily or twice daily on a normal ward. Be aware of phosphate and magnesium losses as well. Those aren't included on your regular use needs, so you're going to have to add them and check them on occasion. But you literally just have to go by what your patient's saying, basically. There's no easy way to teach that when it comes to practice, but you know, you're normally giving potassium or Hartmann's or matched plasma products to try and just replace general losses. I've got a little bit about electrolytes. I'm going to try not to go into too much detail about all this, because it's a bit expansive and beyond the scope of this lecture, but we'll just talk about sodium potassium handling a little bit, and electrolyte patterns to be aware of, and acid-base disorders, which I find helpful. Sodium handling, it's very tightly regulated. A 2% change in your osmolality is going to be detected, and that's going to be enough to cause vasopressin release or activate your renin, angiotensin, aldosterone system. Now, the aldosterone end product of your RAAS system is going to reabsorb sodium and excrete potassium. So it's mostly sodium balance that's going to affect. Vasopressin, this obviously acts on the renal tubules. It's going to insert those aquaporins into the membrane and allow the kidneys to reabsorb basically free water and concentrate the urine. So it's slightly different mechanisms by how they work. And obviously absorbing water with vasopressin expands your plasma volume. Hypernatremia. You tend not to see hypernatremia as much as hyponatremia, and it's generally always going to be hypovolemia. But you know, your fluid balance of the patient, you know, you've got to do a fluid balance assessment and work out, are they dry, are they normal, or have they got too much fluid on board, and that's going to change how you manage them. Majority of the cases you see day-to-day life are due to losses or hypovolemia, and then your fluid replacements. There's other things that are rare and weird, but I'm not going to go into them too much. But but just think about drugs, diuretics, that sort of thing, and things that are going to affect your central control or your renal control of your sodium. Hyponatremia, you know, trying to keep it above 135, but you know, the lower you get, the worse it gets. And symptoms, you know, we get quite worried about hyponatremia and, you know, get people seizing and stuff, but if someone's chronically hyponatremic, they can tolerate really low sodiums very, very well. The symptoms are vague, apart from obviously having low GCS and seizures, you know, you're obviously very concerned, you're going to be checking the sodium. So the rate of change of the sodium is the most important thing that's going to affect how many symptoms they're having. And management is going to really depend on this fluid balance assessment as well. So when you think about hyponatremia, you've got to think, why is it going low? So changes in water balance. So if you're gaining water on its own, I put SIADH in small writing because it's rare. We think about it loads and we talk about it loads, but it is rare. You know, obviously related to some drugs that we give patients, antidepressants, that sort of thing, or, you know, central causes, unusual. Dextrose infusions are giving people glucose. I put in big writing because that's way, way more common. Just look at what fluids we're giving, because that obviously breaks down from glucose into water. Very, very common. Gaining water to a greater extent than gaining sodium. So these are going to be your hypervolemic patients, generally with heart failure, liver failure, or nephrotic syndrome or kidney failure. They're often going to be the chronic hyponatremics that are tolerated fairly well, and you've got to think about your goals when you're treating hyponatremia. These patients are often going to be on diuretics or varying drugs that are going to affect the kidney sodium handling as well. So if in doubt, get senior help. But in general, these are going to be the patients who are going to be water or fluid restricting on the ward, and managing them with diuretics or changes to the diuretics you're going to give. Number 3, sodium depletion. We're going to think about this in terms of renal causes and non-renal causes. Diuretics are put in big writing, very, very common. Cerebral salt wasting syndrome. These are sort of like your head injury patients. I've only really obviously seen that on like the neuro unit. Patients who've had head injuries just pee out tons of sodium, and that's why they're on the sort of like, you know, the 5% saline hypertonics, and it's, in general practice, you're not going to see that very often, so don't worry too much. Just think about diuretics. And then non-renal upper losses, so losing just water through sweat more than you lose the sodium through sweats more than water. And GI losses. Third space losses, again, slightly rarer things, but burns. You see a lot of pancreatitis, to be honest. And your trauma patients, there's this like sort of massive inflammatory response, and they just lose fluid into the extracellular space, and it's third space, they call it. So this is, again, just how you classify it. So hypovolemic, euvolemic, or hypervolemic. Hypervolemic is generally your failures and pregnant patients. Hypovolemics, fairly common. Euvolemics are the weirder stuff, SIADH, SSRIs, that sort of thing. And giving hypotonic fluids, I think will be one of the main things we see in hospital that will sort of drive the sodium down as well. And then we've got this hypertonic dilutional bit at the bottom, a bit unusual, but you know, HHS type patients. If someone's had glycine, so glycine we use in urology cases. So if someone's just had a TURP, you might be thinking about you know, glycine absorption from that. That's a bit rarer. Mannitol, again, sort of an emergency diuretic used for patients with high intracranial pressure, that sort of thing. That's the only real time I've seen mannitol used, but it's rare. But you know, if they've had that, there might be hyponatremia because of that reason, because it's literally just extra stuff in the blood that's diluting it. And then these isotonic pseudo hyponatremia is again extra things in the blood that are diluting it. Again, hyperlipidemia and hyperproteinemia, to the extent that you get low sodium. These are slightly rarer diseases that you wouldn't necessarily be seeing that often, but good to think about. So management depends on, you know, your goals. Are they symptomatic, or do you know, are they, if they're not symptomatic, is it low enough that you're worried about them having seizures? Hypovolemics, you're generally going to be carefully fluid resuscitating them. Hypertonic saline, people often float the idea, but if you're on a normal ward, just avoid it like the plague, because if you correct the hyponatremia too quickly, you cause this horrible, central pontine myelinolysis. It's a disaster, and it's something that's really avoidable. So I wouldn't be messing around with that. That's for ICU, so just leave it. Hypervolemic patients, you often get these fluid restrictions, big signs by the bed, that sort of thing. Patients are variably good at it when they go home, but in hospital you can keep a closer eye. Other things, I've seen really severe hyponatremia from drugs like indapamide, other sort of like weirder diuretics. I have a lot of patients with heart failure and those sorts of things, and that's where you get the like just really odd severe electrolyte abnormalities. So just look at the drug chart or look at what they've been taking. Rule of 6. So they say 4 to 6 is the number quoted now, but if you're going over 6 millimoles per 24 hour, that's too fast. So it's really, really slow, gradual changes. We say 1 millimole. No, sorry. There's an error on the slide. I'm sorry about that. But 1 millimole every 2 hours is a safe upper limit. 1 millimole per hour is too fast. So half a millimole every hour. So I'll get that slide changed for you. If someone's really, really hyponatremic, you're going to need to be either checking the bloods really, really often, which is a nightmare, or you're doing it from an outline on HGU. So you've got to think about, if someone's got a sodium under 120 and they're appropriate to admit, you'd be asking HGU for help, rather than just managing on the ward and giving them, even normal saline with a concentration of 154 millimoles per litre. That's really going to be much higher sodium concentrations than is in their plasma. So you can still get quite rapid sodium changes just from like normal saline. So just be really, really careful with these patients. Myelinolysis, I haven't finished this slide actually. The initial phase mimics that of hyponatremia, so you get this like sort of first phase where they get a bit confused and low GCSE sort of thing, and then later they get this like phase of demyelinolysis. They get like quadriplegias and just horrible sort of like permanent neuronal changes where the myelin sheaths around the cells break down, and it's really debilitating. So it's just an absolute nightmare to treat. So just be really careful with your hyponatremics and your correction. Potassium handling, not going to go into too much, but normal plasma levels 3.5 to 5. Cardiac patients we like on the higher end of that, but if someone's potassium is less than 5, there's no harm in giving them a small bit of potassium in the fluid, in their maintenance fluid if they need it. The plasma levels normally reflect how much total body potassium you've got, but if they've got anything that's going to be driving the potassium into the cells, so insulin or anything that activates your beta adrenoceptors, so salbutamol, or actually just endogenous adrenaline will do that, then the potassium level is not going to reflect their blood level. So it's you've got to think about if someone's been losing potassium or is malnourished for ages, their actual blood plasma level might not really reflect the severe deficit that they have. Renal management, obviously aldosterone is important for that. So any drugs that mess with it, like spironolactone, is going to affect your potassium balance, and generally renal impairment is going to affect your potassium balance as well. A few other minutiae. If you're treating a patient for hypokalemia, if you're giving them the SAND okay and the drug chart and it's just not getting better, just think about checking the magnesium, because it's generally very hard to treat hypokalemia that's also got a low magnesium as well. So just think about that. Oral magnesium is not very well absorbed, so you're going to have to be thinking about giving it IV, but then it gets a bit funny on the ward. A lot of people want monitoring up, or you want to be giving magnesium very slowly, so it's you've got to think about, do we have enough monitoring on the ward to do that, or do they need to go somewhere suitable and get monitored like HGU? But that's it. It gets a bit of a difficult discussion. When I'm in my form year, I'm just like, your name does not have to be on the bottom line for any of these like big decisions. Ask your senior for help and document that you've asked your senior for help. That's the go-to. Discuss with SHO. We love it. Things that we do to treat hyperkalemia. So you give the calcium gluconate, you're giving them insulin dextrose. Some people use salbutamol as well. These are things that are going to cause the body to drive the potassium into the cells, but that's you know, a short-lived thing, and that's not going to treat the underlying cause. So if someone's got, you know, hypokalemia because they've got chronic, you know, renal failure, you're going to get them through that acute phase and protect their heart, but you know, it's going to leach out eventually. So you need to sort of think about what was the underlying condition. You know, the renal failure patients, so obviously go on dialysis for that reason, but you're going to need to keep a close eye on these hypokalemic patients, because you're going to treat them for a bit and then it's going to just leach out again. So just keep a close eye and think about what you're doing longer term. You're going to see your help very useful there. And there's your, you know, crap the bed hypokalemic ECG with those big 10 to T waves. Acid-base states, just one thing to be aware of, alkalosis associated with low potassium states, and acidosis generally associated with high potassium. They're intrinsically linked, and you know, in the kidney you've got all these hydrogen sodium exchanges and co-transporters that are going to manage your excretion, and it's linked with bicarbonate. It's a bit complicated and a lecture for another day. But in general, you're going to see these potassium changes with these states. So just think about if you've got a alkalosis patient and they've got low potassium, correcting the alkalosis may be the right thing to do, as well as giving them potassium. This was a bunch of just an insane amount of birds that arrived on the beach in Peru, and I thought it was a great picture. It's just nuts. No idea why. Resus, last section about giving fluids. Again, really, really dry, but you know, your patient's hypovolemic, they're tachycardic, hypotensive, rubbish cap refill, they're tachypneic, and you want to check with a passive leg rate whether they're going to be fluid responsive. But you know, if you've got all these other things, you don't even need to do a passive leg rate. You're going to be giving them some IV fluid, right? Young patients are going to compensate very, very well. You often don't get young sick people, but you know, you occasionally see one. You know, people, cyclists with a low resting heart rate, you're going to have a relative, you know, a heart rate of 70 might be a tachycardia for someone. If their resting heart rate is 40, and they compensate really, really well, and then they fall off a cliff, so just be careful there. So think about your goals. We're trying to make sure that there's enough volume for the heart to pump oxygen to the tissue. So oxygen delivery is the main thing, not just getting fluid in. On the wards, we generally don't have fluid warmers. We're going to be diluting clotting factors and that sort of thing. It's actually, I think there were some interesting studies we were hearing about from people dealing with like major traumas outside the hospital, and they're doing, like, you know, saline versus blood versus nothing, and the saline was actually a lot more harmful than we thought in those, like, you know, these severe trauma cases. But that's probably because, you know, heme dilution and cooling, not ideal. Fluid overload as well, we've got to be careful with, and some patients could be more at risk of that than others. Crystalloids okay. Colloids not been shown to be any better, so you know, we generally go for crystalloid, and this is where you can be banging in bags of saline just to get someone stable in A&E. Often we use that a lot, but Hartman's and plasma light, you can't go wrong either. How are you going to give it? 500 ml boluses, generally pretty safe. You just want to make sure that you check if they respond to the fluid, and that's the take-home message here. If you're giving fluid and you're giving more fluid and giving more fluid and it's not working, you've got to think why. Have they got, like, you know, big septic dilated peripheral vascular system, in which case they're going to need something to squeeze it rather than just put in the fluid that's going to shift into third space and do more damage. You know, this was referencing at the bottom study about septic patients. Only about 50% of patients have been shown to be fluid responders as well. So stay with the patient and just check what you're giving is working. And if it's not, you're either giving more and then asking for help, or is giving fluid the right thing. I would give up to, you know, 3 500 ml fluid boluses before you think, like, you know, what's going on? Why is it not getting better? Do they need extra help? Do they need HTU? I need some senior support, sort of thing. A note on cannula gauge. It's generally not going to make a difference. You know, if you're using these sort of pumps and you program it in, and it only gives over 15 minutes anyway. But if you want to give a lot of fluid quickly, get a decent sized cannula in. it's difficult when someone's like, really shut down or whatever. But if they've just got a little blue in their ACF, it's going to take 7 minutes to give 250 ml bolus, which is just an insane amount of time. Sometimes if you want to give it quick, you need something slightly bigger. Generally, a green will get you there, but if you want to go really quick, then you get a grey. Special cases. So we mentioned septic patients a few times. The ICU quoted figure is 20 mils per kilo. That's about 1,500 or 300-500 ml boluses. And if even if after the first litre you're not seeing a beneficial change like a decrease in heart rate or them looking better or any increase in blood pressure, ask for help. We had a really good call sort of like last year from the surgeons of a patient on the ward, and they were like, I've given them a litre of saline and nothing's changed. I'm really worried about them. And it was good they called our team, because this patient's spleen had literally like spontaneously ruptured on the ward, and they noticed because they gave a litre of fluid and nothing changed. So it's important to just monitor the response. For septic patients in particular, if they appropriate for ICU, and they're not getting better after this initial fluid resuscitation, the evidence shows that giving more fluid might not help. So that's when you're going to need to get some senior help and ICU. You might notice a recurring theme of asking for senior help. It's generally a good thing to do. Heart failure patients, think about why you're giving the fluids. Obviously, you think about that Frank-Starling curve, and if they go over that hump, giving more fluid actually makes their heart function worse. So just be a little bit careful, but also be aware that they're never going to get their blood pressure as high as someone with a good pump. So have a look at the previous obs and just check, are they always there, or actually has something changed, and why are they hypotensive more than they used to be? Generally a safe thing to do for these patients and your old tiny elderly care patients, 250 ml bolus, and see if it works. Even the most stringent cardiologist is not going to tell you off for giving a 250 ml bolus because you think someone's like septic and hypotensive. It's okay. Also quality of life, mental health, and just you'll be shredded if you're giving loads of fluids to someone on diuretics. So just pick one or the other. Are we giving fluids or are we giving the diuretics? If you give them both, people tend to sort of scratch their heads. You're just sort of like whacking their kidneys for no good reason, and it looks a bit silly. So just check the drug chart. These are some cool chrysalises we saw at a butterfly sort of farm. And this is coming to the end of the lecture now. So summary is keep it simple. Think about maintenance fluids. Am I replacing losses, or am I resuscitating the patient? And there's three main modes. I didn't really mention blood, but you only give blood if you really need to transfuse someone, aren't you? You're not going to use it for necessarily just normal fluid volume loss, are you? Get to know what's in the bag. So look at the bag and work out, what electrolytes am I replacing and what do I need? And do what you can. If it's not working, get your name off the bottom line. Ask your SHO, ask your reg or consultant. Because if you follow these rules, you won't get into trouble. And if it's not working, you've got to think why. And people will help. There's always someone you can speak to. I think that's all I have to say. So I've got better sources than that. I can get a copy of this sent out with the proper articles that I've used to make this lecture. It's a mixture of this and sort of anaesthetic e-learning as well. So I can send that out to you. I hope you've enjoyed that. So thank you very much. I'll be taking questions as well if anyone wants to ask anything in chat.
I think there's a couple of questions in chat, Ben, one or two if you want to answer them. I just want to thank everyone for coming. Everyone's starting to leave. Just before you leave, can you please just fill out the Survey Monkey. I've posted it on the group. It literally takes less than a minute. It's just a couple of tick boxes, and then it's just a way to give Ben the recognition for giving up his time and doing this for everyone. So if everyone could do that, that'd be absolutely great. Cheers.
Okay, and I'll just respond to some of these questions. So SIADH, is it often a diagnosis of exclusion? You'd only really put hyponatraemia down to this if other causes have been excluded. Yeah, I think so. You've got to have a fairly good reason to think it's that. There are the reason being there's other more common causes of hyponatremia to think about. So yeah, I wouldn't be going around just saying I think it's SIDH, even if it might be. You know, it's rarer, and it's normally got a good cause for hyponatremia. I will share the slides. I'll just get a hard copy of them, and I'll put the proper articles in. I've used a various varieties of like BJA articles, mostly focused around perioperative fluids, but I think the principles draw across to general practice in hospital quite nicely, I think. Someone has reduced skin turgor, but normal observations. Do you do a fluid bolus or just maintenance? So it depends on the patient. So if it's someone, reduced skin turgor is not the best sign, and that's why I haven't really talked about it. You know, in elderly care, they're a bit saggy, and everyone has reduced skin turgor. But you know, if you've got a young person and you think, you know, why is it like that? It's kind of useful. Mucous membrane is kind of useful, but that alone wouldn't really direct me. If someone has normal observation, that's probably a stronger sign. Are they thirsty? Just ask if they're thirsty. That's going to give you a good idea as well. So skin turgor is kind of useful, but use it as like part of your general picture. It's not the be all or end all, and that's why we don't often mention that. Glucose 4% with saline 0.18%. So in general, that the reason I've put that in the slideshow is it's our general maintenance fluid. It's isotonic, but obviously the glucose bit is broken down into water eventually. So it's to maintain someone's total body water, if you get what I mean. It will redistribute to intracellular, extracellular compartment and the plasma a little bit. So we generally give that as a maintenance fluid for adult patients. It has a little bit of saline in there, so that'll give you daily salt requirements. And you can add potassium into the bag. Often they'll be bagged with 20 or 40 millimoles of potassium in. So that's just a general maintenance fluid, and we're given that based on body weight. So it's normally around 1 ml per kilo per day. No, it's normally in the same bag. So it's you know, dextrose 4% with 4% with 0.18% saline in just one bag. Generally, we don't nowadays add potassium to the bag, because that's where you have, like, you know, 20 millimoles of potassium in a small thing, and there's just a risk of you know, giving someone strong potassium by accident into the vein and killing them. So we normally have pre-made bags of 20 millimoles or 40 millimoles in a litre of other fluids. So they'll be together. Has it been recorded, Brad? Someone's asking.
Yeah, it's been recorded. We've got like a YouTube where you can access it and stuff. I'll pop that on later on.
Cool. I'll just get together the sources I've used on the article, and then I'll send Brad a link to email out to all of you. Thanks for turning up and giving up your Monday evening, and hopefully see you next time.
Cheers, guys.
Cool. How do you want me to send you the slides, Brad? Just email to you.
If you got my email.
Maybe.
If not, I'll
just text it to me. Just text it.
Yeah, I'll send you the I'll send you my email. Thanks so much for doing this. It was really, really good.
No worries.
Really helpful. It's great that we got so many people, and
I know, what a turnout.
From all over as well. Hopefully, we get a good amount of people filling out the feedback. I'll collate all the feedback for you. Put it all into some nice charts and stuff, and send it you with like certificate and stuff like that for your portfolio.
Happy days. Right. I'm gonna head out and get some dinner.
Yeah, mate. All the best. Nice to see you.
Cheers, bye.
See you later, mate. Bye bye.